Hello, medical professionals. Welcome to another essential guide for your practice. Today, I'm breaking down the UK Advanced Life Support Guidelines for managing supraventricular tachycardia, or SVT. These guidelines are crucial for ensuring the best patient outcomes in emergency situations. First things first, assess and stabilize the patient. This initial step is vital to ensure that the patient is in a condition where further interventions can be safely administered. Check the airway, breathing, and circulation. Administer oxygen if needed. Oxygen can help alleviate symptoms and stabilize the patient's condition. Obtain IV access and monitor the ECG, blood pressure, and oxygen saturation. Continuous monitoring allows for real-time assessment and quick response to any changes. Now, evaluate the patient's condition. This involves a thorough assessment to determine the severity and underlying cause of the SVT. If they're unstable, showing signs of shock, syncope, heart failure, or myocardial ischemia, proceed immediately to synchronized cardioversion. This is a critical intervention to restore normal heart rhythm. If the patient is stable, continue with pharmacological management. This approach can often resolve SVT without the need for more invasive procedures. For stable patients, start with vagal maneuvers like the Valsalva maneuver or carotid sinus massage. These techniques can help to slow down the heart rate by stimulating the vagus nerve. Reassess the rhythm after each attempt. It's important to monitor the patient's response to these maneuvers to determine the next steps. If vagal maneuvers don't work, administer adenosine. This medication can quickly terminate SVT by blocking the AV node. Give a 6 mg rapid IV bolus. This initial dose is often effective in restoring normal rhythm. If there's no response after 1-2 minutes, give 12 mg. This higher dose can be more effective if the initial dose fails. You can repeat the 12 mg dose once more if needed. It's important to follow the dosing guidelines to avoid complications. If adenosine is unsuccessful or contraindicated, consider IV beta blockers like metoprolol or calcium channel blockers like verapamil. These medications can help control the heart rate. Be cautious with these drugs if there's any suspicion of Wolff-Parkinson-White syndrome. This condition requires a different management approach. If pharmacological treatments fail, consider synchronized cardioversion, starting at 120 joules biphasic. This procedure can be life-saving in refractory cases. Ensure proper sedation before cardioversion in conscious patients. Sedation helps to minimize discomfort and anxiety during the procedure. For recurring or refractory SVT, look into underlying causes and treat accordingly. Identifying and addressing the root cause can prevent future episodes. Consult with a cardiologist for further management and a possible electrophysiology study. Specialized input can provide additional treatment options. After successful cardioversion, monitor the patient closely and consider maintenance therapy to prevent recurrence. Long-term management is key to preventing future episodes. If SVT persists or the patient becomes unstable at any point, proceed to synchronized cardioversion immediately. Quick action can be critical in these situations. Remember, this algorithm should be applied in the context of the patient's overall clinical condition and any underlying cardiac pathology. Each patient is unique and requires individualized care. Be ready to switch to the cardiac arrest algorithm if the patient's condition deteriorates significantly. That's it for today. Always be prepared for any eventuality. Stay tuned for more medical insights and updates. Thanks for watching. Your dedication to continuous learning is what makes a difference in patient care.